Assalamu alaikum. Ladies and gentlemen, Mr. Shalman, good morning. I'm going to speak about endovascular treatment of aortic thoracic trauma. And I start with the first cases. Male, 70 years old, fall downstairs. He presented hemoptysia. CT angioscan showed the rupture traumatic in bronchus. He died at his arrival in emergency. The second case, male, 28 years old, polytrauma, splenectomy, extradural hematoma operated. The CT angioscan showed that he had rupture of isthmus with fracture pelvis. We treated by endovascular treatment with good evolution. So traumatic aortic rupture are the most common vascular lesion during blunt thoracic trauma. It's fatal in 18 to 19%, and the second cause of death after heat trauma. They have no specific clinical symptom. The diagnosis is always made by CT angioscan, and lesion of isthmus is about 75%. For our series, we have treated 23 thoracic aortic trauma, 21 by TVAR, the majority was man, and the mechanism was road accident. Over the past 3 decades, aortic repair has progressively evolved from exclusively open to almost exclusively endovascular repair. Our recommendation now are for TVAR and for all age group with appropriate anatomy, because the patient often suffer from multiple organ trauma, placing them at a high risk for open surgery. So in summary, endovascular treatment had many advantages, especially the possibility to perform the procedure under local anesthesia, but it needs accurate sizing, availability of material, trained medical staff, and long-term monitoring, because we don't know the becoming of the material, especially in young patients. So for the timing of the aortic repair, the strategy most often described in literature for the severe aortic lesion, it requires immediate repair, and for the older, they should be undertaken after hemodynamic and respiratory stabilization of the patient and management of immediate life-threatening lesion. So for the sizing, we must be careful, because with patients with hypovolemia and estimation of the TVAR size may occur due to vasoconstriction in case of hemorrhagic shock linked to small aortic caliber. And we may also be careful with the angulation, the arch type, because most often young people have type 3, and the angulation for the landing zone that must be more than 20 millimeter. And sometimes the angulation is very severe, so it makes a challenge for on a TVAR. For the proximal landing zone, half of our patients need zone 2. And when we have landing zone 3 or 4, it's easy for endovascular. The problem is when the artery is close to the subclavian artery. There is no recommendation for coverage, endovascular, total endovasculars, or hybrid technique. So some author, when it's extreme emergency, cover the subclavian, but they must pay attention to left vertebral artery and make an assessment for cerebrovascular anatomy. So we do, for the hybrid technique, we can do transposition or bypass. We do it for 2 patient transposition and 6 patient bypass. And for total endovascular, we don't have a branched TVAR in emergency, so we can do a Chimney technique. We do it for 2 patients, and this is the result. For zone 1, we treated 3 patients. We do a bypass for 2 patients with the branching and Chimney technique for 1 patient. And this is a young man who had a rupture isthmus with severe angulation, so we have a problem to push the TVAR in the aortic arch, so always it go trunk of brachiocephalic, so we put a balloon before to advance the advice. For the zone 1, it's need the total debranching with before the TVAD, we do it for one patient. So we have 100 successful technique, no stroke, no paraplegia, and no patient died from aortic rupture while waiting repair. So, and only 57% of TVAD patients were fearful compliant with their surveillance imaging protocol. In conclusion, endovascular treatment of aortic thoracic trauma appear to be a suitable alternative to open surgery with favorable results. The most recent guideline proposed TVAR as the first-line treatment for aortic thoracic trauma. The challenging may be sometimes when we have severe angulation and adherence to follow-up image protocol. It's challenging also in this patient, especially with young population. Thank you for your attention.